Right.
My lady, please can I call Stephanie Howarth?
Thank you.
Just repeat after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth. Please could you give us your full name?
I'm Stephanie Howarth.
Ms Howarth, thank you for attending today and assisting the inquiry. Whilst you give your evidence, could you please try and keep your voice up? This assists people who are listening here, but also helps the stenographer who's making a note of the proceedings. If I ask you anything that isn't clear, please just ask me to repeat. You were asked by the inquiry to provide a witness statement addressing your role as Chief Statistician for Wales, and we can see the statement that you were good enough to provide on the screen before you. Now, you signed this statement on the 15th of January 2024. Is that true to the best of your knowledge and belief?
It is.
If we could please start with a few questions about yourself. You are the Chief Statistician and Head of Profession for Statistics in the Welsh Government, and that's a role that you have held since July 2020.
That's correct.
What are your responsibilities in that role?
So as the Chief Statistician, I am the Welsh Government's Principal Advisor on Official Statistics. I oversee the independent production of official statistics in the Welsh Government. I also have a role as Head of Profession then in building the statistical capability and capacity within the Welsh Government, and I oversee the implementation of the Code of Practice for Statistics.
And is it right that you remain operationally independent in terms of decision-making on matters around official statistics?
That's correct, yes.
Now, we'll come to hear more about its work in due course, but does the Knowledge and Analytical Services, or CAS, within the Welsh Government sit within your directorate?
It does. So Knowledge and Analytical Services is made up of two parts, and the statistics part is the section that I lead.
Now, you have seen the statement that Glyn Jones has provided to the inquiry on behalf of CAS, dated the 8th of December 2023. Do you agree with the contents of that statement?
I do.
So moving to CAS now, please can you briefly outline what CAS is and what its role is within the Welsh Government?
So CAS is a Knowledge and Analytical Services. It's a part of the Welsh Government that brings together the analytical professions, so statisticians, social researchers, economists, to provide analytical evidence and advice for Welsh Government ministers and officials to enable them to do their roles.
And to broadly summarise the work that CAS did during the Covid-19 pandemic, is it correct that it established new data collections, acquired data from other bodies and third-party organisations, provided analysis and advice for ministers and officials on Covid data, including the compilation of weekly data monitors, published and communicated regular Covid-19 statistics, and contributed to the work of TAC, TAG, Public Health Wales, and Digital Health and Care Wales on statistical matters?
That's correct. And also, we maintained a range of our regular statistical publications as well that might not have been specifically about COVID-19, but were still important to understanding what was happening in Wales.
Ms Howarth, is it right that prior to the first national lockdown, neither the Chief Statistician nor CAS in general were actively involved in reporting on or briefing on the spread of COVID-19, as this was being led by Public Health Wales and by TAG?
That's broadly correct. So from the start of March, Knowledge and Analytical Services has started to become more involved in work around COVID-19, but most of this work in terms of reporting on things like infection levels and deaths was being led by Public Health Wales.
I'm now going to ask you some questions about the data compilations that were provided by CAS during the pandemic. Was the assembly of statistical information about COVID-19 a key strategic priority for CAS and for the Welsh Government at the outset and during the pandemic?
That was certainly one of our main responsibilities, and the bringing together the wide range of data that was in circulation was a key responsibility of CAS to bring all that into one place.
And one such repository of key data or key information for the Welsh Government was the COVID-19 Analysis Hub, which was stood up on the 23rd of March 2020. Is that right?
Yes.
And initially the hub published all new data related to COVID-19 cases and deaths, and this was then later progressed to topics such as care homes, testing and contact tracing. Is that right?
Broadly, so Public Health Wales led on the publication of rapid surveillance data around cases and deaths, and ONS then on deaths data from death certificates. But the hub had a role in reusing that information and bringing it together for use within the Welsh Government.
And how frequently was the data on the hub updated?
It would really vary by source, so there was a range of data sources that we were using. Some of these were daily, so we would use the daily information that was coming from Public Health Wales on things like the number of cases and the number of deaths. There was also daily information around school attendance and the number of people in hospitals, but some other sources would be less regular, might be weekly. So, for example, some data around testing and contact tracing, those things tended to be slightly less regular than daily, but still much more frequent than we might have been used to prior to the pandemic.
Coming slightly later in the chronology was the Covid-19 data monitor, which I understand was produced on the 3rd of April 2020. Ms. Howarth, how was that different to the hub?
So the hub was a structure, it's a team essentially within Knowledge and Analytical Services that was coordinating the role of statistics in the pandemic. The monitor was one of the products that the hub produced, and it was a compendium of statistical information about the pandemic, so that information was there in one document and could easily capture the trends around Covid-19 and its associated harms in Wales.
You've alluded to it already, but am I right in saying that Public Health Wales also published their own weekly Covid-19 data, including their Covid-19 data dashboard, which was circulated around senior Welsh Government officials and ministers?
Public Health Wales would publish daily this information on their dashboard around cases and deaths and testing. The Welsh Government, if we're talking about the data monitor here, this wasn't something that was initially published. This was something that was circulated within the Welsh Government, although in time it did become a public-facing document.
Can I just interrupt for a second? I'm afraid you've both got the same failing I have, which is speaking very quickly. So
yes, please do remind me of that.
Both, yeah, well, I'm afraid it's something I have to remind myself of on occasion. Thank you.
Thank you, my lady. By April 2020, if I were, say, a senior government official and I wanted to understand what was happening in hospitals, is it right that I could check the data monitor published by CAS or the Public Health Wales weekly dashboard or any of the other publicly available information from, say, the ONS?
So for information about hospitals, that was broadly made available within the Welsh Government. So the data monitor would have been one of the main ways that we circulated that information.
Please can we have on screen INQ 000271847. This is the HSSG response to COVID-19 lessons learned document produced in August of 2020. Ms. Howarth, am I right in saying that CAS contributed to that lessons learned report?
Yes.
If you look please at page 3, in the middle of the column, penultimate paragraph. Not always clear-cut split in responsibilities within CAS between Health Stats and COVID Hub. In the next paragraph, multitude of dashboards being prepared for different purposes, sometimes with similar but slightly different data flows. In terms of Public Health Wales, this was sometimes done without any regard to what else is happening in the system. This then leads to duplication of similar outputs between Public Health Wales and Welsh Government, creates confusion in the media and the public. Was that a fair criticism of the way in which data was presented during the first wave?
I think it's certainly fair to say that data was available from multiple places, and part of the reason for bringing a product like the data monitor together and eventually then publishing it was to have one place that brought together all the key information. But that being said, there were times, and I think that's what this information is referring to, where new things would be published by other organisations, for example, Public Health Wales, that we weren't necessarily aware of in the Welsh Government that were going to happen, which I guess was a missed opportunity to coordinate better and think about presenting one collective message so that you could avoid that potential confusion.
I'm now going to change topic and ask you about NHS management information. We will hear during the course of this module that hospital information was a key part of pandemic response and informed Welsh Government decision-making. Focusing on the early days of the pandemic and the first wave in particular, Was data on hospital admissions to intensive care and admissions in general a critical data set for Welsh Government decision makers during that time?
It was certainly one of the data sets that was used a lot and very significantly, yes.
And we heard this from Professor Sir Diamond this morning, but at that time there was no mass programme of community testing, meaning that hospital admissions was crucial for the government to understand the spread of COVID-19 in communities. Is that right?
Yes.
It's understood that CAS received data from hospitals on admissions due to COVID-19, patients in hospital, suffering from COVID-19, bed capacity, ICU capacity, ventilator figures, and so forth. Is that right?
Yes. Actually, can I just clarify? So we were one user of that data. So the data was collected by Digital Health and Care Wales, and it was provided to the Welsh Government. Initially, it was provided to the NHS performance team, which is part of the health policy area. But CAS was also a team that used that data. So it wasn't coming directly into CAS.
We'll look at some charts based on the data that was provided in due course, but before then, I want to ask, if I may, about some of the limitations of the CAS data received from health boards during the first wave. First, the inquiry understands that there were issues with precisely what was measured and what could be measured in hospitals. Andrew Nelson, the Chief Information Officer at Cwmtag Morgannwg University Health Board, has highlighted the following 3 issues, and I'll read those out. Number 1, before the 24th of March 2020, it was difficult for health boards to even work out the number of admissions to hospital due to COVID-19, as this was dependent on mining free text fields from the emergency department datasets, which would have been prone to error. Number 2, there was no data differentiating community-acquired infections from hospital-acquired infections, meaning that the caseload of COVID-19 in the community could be overestimated or it could be underestimated. And number 3, data did not distinguish between the numbers of patients admitted due to COVID-19 compared to the numbers admitted for a different reason but who happened to have COVID-19.
Do you pause? The transcript's not running. I don't know if it's just mine or whether it's because, no, it is back. I think it's because you were speaking too quickly, Inspector. So we have the last one, the transcripts got recorded. It was difficult for health boards to even work out the number of admissions to hospital due to COVID-19. And there we stop. So that's number 1. So can we finish number 1 and then go back to the others, please? Sorry about this.
Madam, I think that might have been number 3.
No, I think that was...
For ease, I'll go through all of them once again. Thank you, my lady. Number 1, before the 24th of March 2020, it was difficult for health boards to even work out the number of admissions to hospital due to COVID-19, as this was dependent on mining free text fields from the emergency department datasets, which would have been prone to error. Number 2, there was no data differentiating community-acquired infections from hospital-acquired infections, meaning that the caseload of COVID-19 in the community could be overestimated or underestimated. And number 3, data did not distinguish between the numbers of patients admitted due to COVID-19 compared to the numbers admitted for a different reason but who happened to have COVID-19. Do you agree with the issues that Andrew Nelson has identified?
Broadly, but I think there's probably some nuance to some of those. So the second point around hospital-acquired and community-acquired COVID-19, I know Public Health Wales did publish information around hospital-acquired COVID-19. And then the final point was around, I think, those who were in hospital for COVID-19 reasons and those who had, I guess, incidental COVID, for want of a better term, from, I think it was January 2022, so relatively late on, there was information available that made that distinction. But certainly for the majority of the pandemic, that wasn't in place.
Is it fair to say that each one of those issues had the potential to make healthcare data in the first wave less reliable for policymakers?
I'm not a policymaker, so I can't necessarily comment on how the information was used for policy-making purposes. But I think there's a couple of points here that there was a range of statistical information. So you have things like the testing data, the hospitalizations data, and the mortality data. And those things collectively tell you about the trends of what was happening in COVID-19. But then I guess what was it Mr. Nelson who made this statement? I think the point that he's making here is about the underlying health data systems within Wales, and that they perhaps do not offer the flexibility to collect information in new and changing ways. And that's a point I would agree with, that some of these kind of legacy data systems potentially made that more challenging to do at pace.
Moving on from data gathering to data reporting, in a review that was undertaken by the Welsh Government in April of 2020, a number of matters were identified. Please can we have that document on screen? INQ 0000668087 for those following. It's titled Review of Mechanisms for Reporting COVID-19 Deaths in Wales. If we look at page 1, paragraph 6, following the identification on April 23rd of 84 deaths that had now been reported to Public Health Wales by Betsy Cadwaladr, had not been reported, my apologies, to Public Health Wales by Betsy Cadwaladr University Health Board, Public Health Wales and Welsh Government officials have sought assurances from across health boards and trusts concerning the robustness of the current process. And then if we move to under the heading Inconsistent Approaches Across Health Boards, at paragraph 11, on page 2. For example, as a result of not using a single system, Public Health Wales have reported a number of generic issues during the past few weeks, which include delays of health boards in the reporting of deaths, reported ambiguity in the definition of what constitutes a death to be reported through surveillance, and the inclusion of deaths occurring outside of a hospital. And then finally, under the heading multiple reporting streams and unclear reconciliation processes, thank you, health boards are required to report data to a number of different organisations: Public Health Wales, internal briefings to the board and key local stakeholders, to the NHS Wales Informatics Service, and to the Office of National Statistics. These reports have different purposes and often a different basis, which can lead to inconsistency in the results being produced. Did CAS review and agree with each of those findings at the time that this report was produced?
So this report was prior to me becoming chief statistician, so it wasn't something that I was directly involved in. So this was the previous chief statistician who led on this work. But my understanding is that he was involved in developing this report, and so I expect would likely have agreed with those statements.
Please can we now look at, again, the HSSG Lessons Learned Review document at INQ 000271847. In the final paragraph in the central column of page 2. The issues that arose in mortality surveillance are well documented in the review, but could have been avoided via greater roles and responsibilities and adherence to some principles around management of administrative data, which CAS could have advised on. There was a lack of clarity on who was reviewing the mortality data and ensuring LHBs were submitting surveillance data. Ms Howarth, do you accept that finding, that CAS could have done more in those early days to ensure the quality and consistency of hospital data?
So I think the point that this is making is about not hospital data, but about mortality data, which was being collected through the rapid surveillance measures that Public Health Wales had put in place. So this wasn't something that CAS was directly involved in, but it's making the point that the types of quality assurance processes that we use within knowledge and analytical services, these approaches, if we'd been asked to advise on it, would have avoided those kind of errors and that missed reporting happening. It's fair to say that in Public Health Wales, they didn't have government statisticians with the same kind of experience and background that we have in knowledge and analytical services. And if they had, they might have had greater awareness of the kind of toolkits that we use around the quality assurance of administrative data that might have better helped identify that some of these returns were not being made from some health boards on that rapid mortality surveillance.
On what basis do you work? Do you have to wait to be asked to provide a report or to analyse data, or can you do something off your own bat?
So do you mean in terms of working with Public Health Wales or more generally? Yeah. So I have a role as a kind of a leadership role across the official statistics system, but generally it would be that people might come and ask for our advice on particular topics. and that has happened on regular occasions. But throughout the pandemic, it was perhaps more that we were proactive in giving that advice because the lack of experience, I guess, in Public Health Wales in using the Code of Practice of Statistics, for example.
So during the pandemic, you became proactive, but generally you would wait for the statistician at statisticians, never say the word, at Public Health Wales to come to you and ask for help or advice.
In normal times, yes. We do have a regular 6-monthly get-together of all the official statistics producers in Wales, which is an opportunity to understand what each other is working on in normal times. So yes, normally we would expect lead officials in each organisation to raise issues with the chief statistician.
I'm sorry to take you back to right at the beginning. I'm sorry about this, Inspector. I'm sorry to interrupt. But when you didn't get involved until the first lockdown, so the Public Health Wales statisticians were doing the work at that stage. Do you think it might have been helpful if your department had been asked for its assistance earlier on?
Potentially. I mean, the role of reporting public health statistics is a role for Public Health Wales. But I think this experience has shown that the value that government statisticians can bring in terms of both the quality assurance of data and the ability to communicate that data as well and understand user needs. And I think that there was potentially an opportunity that we could have got involved earlier.
Yeah, thank you. Sorry to interrupt.
Not at all, my lady. I'm now going to ask about a different aspect of Wales's healthcare data management. The inquiry understands that Wales occupies a unique position within the UK due to its secure anonymised information linkage, or SAIL, databank. Is that right?
Yes.
To begin, can you explain what that databank is and what it does?
Certainly. So the SAIL databank is run by Swansea University. It's what's known as a trusted research environment. So it's a secure virtual environment where data can be deposited and researchers can apply to use that data for public good research purposes. And the thing that's particularly unique about the SAIL databank is that all these different data sources can be linked together in a secure and anonymised way, so you can learn more about a particular topic than you can from using any of those individual data sets in isolation.
So the value is as much in the linking as it is in the collection of that data?
Yes, definitely.
The inquiry understands that during the pandemic, many relevant data sets were supplied to SAIL to enable them to be linked, including data relating to social care workers, children's attendance at schools, emergency department data sets, data from healthcare workers, risk assessments, and the Zoe symptom tracker app. Is that right, by way of example?
Yes, I believe so. Not all of those would have come from the Welsh Government, but that's the kind of data that would be available in SAIL, yes.
Was CAS and TAC able to use this kind of data linking to support analytical work required in the pandemic response?
Yes, it was used considerably.
What kind of work was able to be done with it?
So there would be work carried out either by analysts based in the Welsh Government or through the academic community as well. We brought together this One Wales partnership, it was called, which was looking to bring together those with relevant experience in this area to support the pandemic. Some examples of the kind of work that my team did were things like linking together the shielded persons list with other data sources like the school workforce census, for example. So that could tell us about the number of teachers and school staff who were on that shielded list, which you can then use to help inform planning for return to school.
For our purposes today, I want to look at the work SAIL was and perhaps was not able to do concerning COVID-19 datasets and some protected characteristics. The former Chief Statistician, Glyn Jones, said in his statement to the inquiry, a key challenge identified early on was the quality of data held by the NHS on ethnicity and the availability of COVID mortality data by ethnicity. Do you agree with what he has said in his statement?
Yes.
To run through some of the challenges that he describes, data on ethnicity is not recorded on death certificates in England and Wales. We've heard about that already. Many healthcare records do not record the ethnicity of the patient. Initial reporting of COVID-19 deaths in confirmed hospital cases through the Welsh Clinical Portal surveillance form did not record ethnicity before May 2020. And then there's the Is Wales Fairer report in 2018, which had already commented on the clear gaps in the data in Wales on protected characteristics. Is all of that correct?
Yes, that's correct.
What all of this meant in practice was that the data we've described on hospital admissions, on ICU admissions, deaths relating to COVID and so forth, none of that could be grouped by protected characteristics like ethnicity. Is that right?
Some of it could be, but there would be some weaknesses in the data, and that's where the acquisition of the 2011 census was so valuable. So the former chief statistician had made the case for that to be deposited in SAIL because it was so valuable in improving coverage of things like ethnicity within that data set. So as an example, I think I recall a colleague saying that it improved missingness within the ethnicity data set from around 30% missingness to 10% missingness. So you've still got some records that do not have ethnicity data within them, but considerably fewer than prior to bringing in the census data.
If that's the census data, moving on from that, the evidence that the inquiry has heard is that England has significantly more detailed information on ethnicity and other socioeconomic categories to link to COVID-19 outcomes, as much of this had been taken from English GP records. Now, we've heard that Wales had the benefit of the SAIL data bank. Why could this be done in England and could not be done in Wales?
I'm not sure I'd agree with that, because I think GP data is available within SAIL and a range of other data sets as well, which bring together a whole range of different characteristics. That's a very strong position in Wales, that we've had all this data available to link for a number of years. I think perhaps the question here is about where that data is held in different places. So I know Ian Diamond talked earlier about not being able to carry out specific pieces of analysis within ONS because ONS didn't hold the data. But that data did exist in SAIL, and it's more that ONS hadn't used the data in SAIL. It wasn't that it didn't exist in a linked format in some way. So ONS only had access itself to information about England.
So in summary, it was more of an access issue rather than not having the data or having not linked the data?
Yes.
I'm sorry, I'm not following Spector's question. Was why is it England had better ethnicity data than Wales? Is that right? Is that the question?
My lady, the question was more related to the fact that does it seem to be the case that that data could be extracted from English GP records when GP records exist in the SAIL data bank in Wales?
But was the introduction to that point that England had better ethnicity data?
Yes, my lady, yes.
I don't think you've answered why did England have better ethnicity data than Wales, as far as I can tell, but maybe you have and I've misunderstood.
No, that's a fair question. And I don't know if England does have better ethnicity data than Wales. My understanding was that if you're looking at health records, for example, there are common challenges across both health systems, and that's why linking data together is so beneficial.
To perhaps put the question in a slightly different way, do any gaps remain in the CAS and the SAIL data sets in relation to the ability to disaggregate health information by protected characteristics?
There are certainly a range of issues related to availability of data on protected characteristics, and they would affect data available in SAIL, but also data that exists outside of SAIL as well. And we've already noted ethnicity being one particular example. I think that's particularly acute for Wales because Wales is a small nation with a small ethnic minority population. So if you are collecting data through surveys, for example, you have to have a very large survey in order to be able to break the data down by different ethnic minority groups. So that's a particular challenge. There are other challenges related to disability, for example, where most data is collected under the medical model for disability. We do not, as a statistics system across Wales or the UK, have an established method for collecting data through the social model for disability, although that is something we're actively looking at the moment.
Moving on now to data on social care. Yesterday, this inquiry heard evidence from Helena Herklotz, the Older People's Commissioner for Wales, who described that initially in the first wave, the data on deaths from COVID-19 did not include older people who died in care homes. Is that correct?
So perhaps it would be helpful to set out the two different sources of data around COVID-19 mortality. So you have the rapid surveillance data that is collected by Public Health Wales that comes through their e-form that was used to collect this information. That information predominantly focused on deaths in hospitals. My understanding is it was never designed to be full coverage of all deaths. It was about being able to rapidly identify trends in mortality. So it may have captured some deaths in care homes, but it wouldn't have captured all deaths in care homes. The ONS data, which comes from death certificates, would capture all deaths and would be attributed to COVID-19 where that was mentioned on the death certificate.
Are you able to assist us with a date when the Welsh Government was in receipt of reliable and comprehensive data of all people who died in care homes due to suspected or confirmed COVID-19?
That would have come from the ONS data, which would cover all care homes. There was also an additional source from Care Inspectorate Wales. So Care Inspectorate Wales is required to be notified of a death of a care home resident, and the Welsh Government had access to that information from relatively early on in the pandemic. I know we began publishing it from early May, but we would have had access to it internally earlier than that.
Now, the ONS has published a number of blogs and lessons learned reports during the course of the pandemic, and one of these is called Glimmers of Light for Adult Social Care Statistics, dated the 8th of July 2021, which you can see before you on the screen. That blog summarised the concerns that the ONS have been raising relating to adult social care in Wales and amongst all UK nations. It's not unique to Wales. Its findings, as you can see on the screen before you, were that, number one, adult social care has not been measured or managed as closely as healthcare, with a lack of funding leading to underinvestment in resourcing and data and analysis. Two, there is an unknown volume and value of privately funded provision of adult social care. Just moving on. Robust, harmonised data supply to ensure comparable statistics from both public and private providers is problematic, as data collection processes are not always standardised. And moving on, data quality is variable within and across local authorities, with inconsistent interpretation of data reporting guidance by local authorities. And the post goes on to say, just in the next sentence below, as data issues go, as the pandemic has highlighted, there is not so much a gap as a chasm, with consequences to our understanding of social care delivery and outcomes. Now, as I've said, those findings are not addressed uniquely to Wales, but is it fair to say that these problems persisted in Wales in March 2020?
Yes, I think that's a fair summary.
Now, in terms of listing the changes that have been made since then, the blog proceeds to list 5 tangible changes being made by the UK government on this issue for data in England, such as the monthly publication of a statistics report on adult social care in England. Just regarding actions being taken in Wales, the post simply says the Welsh Government remains committed to improving the data it captures on social care. So can I ask you, what is the Welsh Government, assisted by CAS, doing on this issue?
So I think there's probably 2 different strands to this. There's things specifically related to the pandemic, and then there's social care data more generally. So during the pandemic, I've already mentioned the data that was available from Care Inspectorate Wales. So that was a new source of information that we began using to learn more about the pandemic and how it affected care homes. We also stood up a weekly, what we refer to as a checkpoint survey of local authority social services. Social care and social services generally doesn't have the same kind of timeliness of information that the health service has. And so this weekly survey was a way of understanding the demand and local social services' ability to respond to that demand during the pandemic. Outside of the pandemic, more broadly, we've been putting a lot of effort in recently into improving data around adult social care and adult social services more broadly. So this year, for example, we will start collecting what we're calling an adult census of people who use social care services. So that will give us much more granular information about people who use local authority social care services.
Moving on now to occupation data. Another group at higher risk of contracting COVID-19 were healthcare workers and social care workers. With that in mind, please can we look at document INQ 000395589. If we could please go to the bottom of page 4 and the top of page 5. This is an email thread between members of Public Health Wales about data reporting in Wales, and we can see that Dr. Frank Atherton was copied into those emails. The first email in the thread was sent on the 14th of April 2020. And if you look at that first sentence that's highlighted in yellow, they, meaning the ONS, are looking at developing a new process for capturing deaths in HCWs, healthcare workers, and adult SCWs, social care workers. This was discussed with the DAs at the weekend and is under review. And then if we scroll up to the thread on page 3 in an email sent on the 15th of April, again from a member of Public Health Wales. And if we look at the second sentence highlighted in yellow, DHSC/PHE are asking the DAs to confirm what they are doing about information about staff number deaths, would like an update on this urgently. And in the next email thread, at the bottom of page 2, an email from a further member of Public Health Wales reads, in meeting with Minister, meaning Vaughan Gething, where he agreed we hold our line that there is no reporting on NHS staff deaths in Wales by Public Health Wales. And then the final email in that thread on page 1 says, we do need a handle on HCW deaths ourselves. In March and April of 2020, do you know whether CAS was asked to assist Public Health Wales in identifying healthcare worker or social care worker deaths?
I don't know if we were asked in that specific period. It wasn't something I was involved in, but I do know that Public Health Wales did add a flag around healthcare worker deaths and social care worker deaths in their e-form that they use for rapid surveillance mortality purposes as a way of helping to collect this information.
Do you know when that took place?
I think that was added in early May from memory. I do know also that colleagues in Knowledge and Analytical Services asked the Office for National Statistics as well to provide information from their mortality data that would tell us the numbers of healthcare workers and social care workers in Wales who had died from COVID-19.
Do you know what the argument was in relation to no reporting?
I don't know. My suspicion might be that it was because there would perhaps be very small numbers and you might not want to disclose some information about someone that wasn't public, but that's just a guess.
Mm-hmm.
In your opinion, was that an important data set to try and receive?
Yes, there was certainly a lot of interest in understanding the potential risk that healthcare workers and social care workers were experiencing, and having reliable statistics on that was an important thing to be able to do. The differentiation I should probably make, the ONS data doesn't necessarily tell you about in-service deaths from COVID-19. So it would tell you whether someone had died from COVID-19, but not necessarily whether it was something that had been acquired in the line of work, for example.
Moving on now, we'll look at some of the charts that you provided with your witness statement concerning COVID-19 infections and hospital data in Wales. So first, please can we have figure 1A in your witness statement, INQ 000399709. This illustrates the weekly hospital admissions for COVID-19 and non-COVID-19 conditions in Wales from March of 2020 to June of 2022. Are you able to explain to us what this chart shows?
Yes, so this is the weekly hospital admissions for COVID. It includes both suspected and confirmed cases, and you can see that blue line at the bottom shows the COVID-19 cases with some distinct peaks in the early phase of the pandemic in sort of March, April time 2020, and then other peaks towards the end of 2020, early 2021.
If we could now please have on screen INQ 000412041 in the slide on page 2. This chart shows the number of beds available compared to the number of patients across hospitals in Wales. And we can see here that the pale orange line represents confirmed and suspected COVID patients, the orange line designated COVID beds, the pale blue line total patients in hospital, and then that dark blue line all general and acute beds. For clarity, am I right in saying that that red line for designated COVID-19 beds does not represent maximum capacity for COVID-19 patients in hospital, because designated for beds that were not designated for COVID-19 could still be used for COVID-19 patients?
Yes, that's correct. Generally, we would look at occupancy across the hospital as a whole rather than designated COVID-19 beds per se.
With that caveat in mind, are you able to talk us through what this chart shows?
Yes, so if we're looking specifically at the COVID-19 series at the bottom there, it follows a similar trajectory to the admissions data in the previous slide. It shows that there were peaks in the spring of 2020 and again in late 2020 and early 2021, and that at times the number of confirmed and suspected COVID patients was close to or slightly over, in some cases, the designated COVID beds, although noting that there would still be other capacity available.
And can we also see that the availability of those COVID-19 designated beds was more limited in the second wave than in the first wave at times?
Yes.
We're going to hear about decisions that were made in Wales in waves 1 and 2 based on concerns about hospital capacity later in the next 2 weeks. This chart suggests that capacity was never near to being meaningfully exceeded in Welsh hospitals. However, the figures that we see are combining all hospitals and health boards. Are you able to assist us with whether there were certain hospitals or health boards that were more consistently near or at capacity during the COVID-19 pandemic?
I'm afraid that's not a level of detail that I can help you with.
If we now look at the chart on page 5 of INQ 000412041. This chart shows invasive ventilated beds in Wales, April 2020 to June 2022. Just again, are you able to talk us through what we can see in this chart?
Yes, so there are two series here. The blue line represents the number of invasive ventilated beds that are available. These would typically be in a critical care environment, but not always in a critical care environment. And then the yellow or orange line is the beds occupied, and that is for both COVID-19 and non-COVID-19 patients. Similar to some of the previous series, you can see some distinct peaks in the early and second phase of the pandemic. If we look at beds available, there were a larger number of beds available that offered invasive ventilation earlier in the pandemic, and then that drops after the first phase.
I'm grateful. Finally, I want to look at some charts concerning COVID-19 and discharges from hospitals into care homes in Wales during the pandemic. Now, the ONS has published figures that there were 13,630 deaths in care homes overall in Wales during the COVID-19 pandemic. Just over 30% of those deaths were registered during the first wave, and 40% or so of those were registered during the second wave. Is that information correct?
I don't have the figures to hand, but that sounds correct.
We've discussed already a reason why those numbers might have been slightly underreported in care homes in the first wave. Is it likely that official figures of deaths caused by COVID-19 in care homes in the first wave might be even lower still, because there may have been undiagnosed COVID cases due to less testing and less clinical experience of staff in the early days of the first wave?
That is potentially possible, and I think that would be the same case for deaths outside of care homes as well. And that's why sometimes it's helpful to look at excess deaths overall rather than just COVID or non-COVID deaths.
Please, can we now have on screen INQ 000271757? Now, am I right in saying that this is research that CAS conducted into discharges from hospitals to care homes between March and May of 2020?
Yes, that's correct.
And we can see from the top of paragraph 2, page 1, CAS analysed 1729 discharges from hospitals to care home settings, analysing how many patients were tested prior to discharge and how many of those patients subsequently passed away. That number, 1729, can I ask, was that all discharges from hospitals to care homes in Wales, or was it a sample size that had been taken by CAS?
This analysis was it started before I was chief statistician, so I wasn't involved at that time. But my understanding is that should be all the discharges that were able to be identified at that point.
And what this study did is it counted those who had themselves been discharged from hospitals into care homes and died, rather than those who might have been infected from someone being discharged with COVID-19 into a care home and who then subsequently died. Is that right?
Sorry, could you repeat that?
I can. The study counted people who had been discharged from hospital with or without a test and who had subsequently died from COVID-19, rather than people who might have been infected by those people who had been discharged without a test.
Yes, that's right. It didn't attempt to look at that issue around whether discharging from a hospital to a care home was related to an outbreak of COVID-19. It was simply looking to describe the number of discharges that happened and the testing activity associated with that. There was other work that had tried to look at that more complex question.
If we look at the final paragraph on page 1, of the 81 discharged patients who, by the point of data extraction on the 30th of June 2020, had died of COVID-19 related causes, 62 did not receive a test in hospital prior to discharge. If we then look at page 7 in the chart in the middle of that page, which is chart 3, that chart shows the proportion of discharges to care home settings where a test was taken in hospital prior to discharge and those that did not have the test. And we can see that dark blue there is no test taken. If we focus on the week commencing the 27th of April, and that bar, we know that the Welsh Government announced on the 24th of April that mass testing would commence for all patients being discharged to care homes, which was followed by new guidance on hospital discharges on the 29th of April. But we can see in that bar for the 27th of April that the number of patients discharged without a test continued, given that we can see some navy blue space at the bottom of it. And we can see that that continued to the end of May. Is that right?
That is what the chart shows. I guess there could be some occasions when it might have been a data issue that we couldn't necessarily link a discharge record to a testing record. That could be a recording and reporting issue, but I couldn't say that with certainty. But it does show within the data that there were some discharges that did not have a test record associated with them after that point.
And if we then go to table 3 on page 8, that slightly breaks down the numbers of discharges that we're talking about in the period that we're looking at. We can see that for certain health boards, the figure of discharges after the change of guidance was as high as 50% in April and 29% in May, so after the policy change. Is that right?
That is right, but it's worth noting that there are some very small numbers involved there. So the Hywel example in April, for example, is one, which leaves a percentage of 50%. So it's useful to look at the numbers as well as the percentages.
And if we look at the numbers for Aneurin and Bevan for May, that gives us slightly higher, not much, but a slightly higher number of discharges, and we get the 17% there. In terms of the conclusions that could be drawn from that table, what is it that CAS concluded looking at those results about the discharges that were continuing despite the change in guidance?
I think our conclusion was that there were still some records where there appeared to be a discharge from hospital to care home without a test record after the point at which the guidance changed. That could be because it wasn't possible to link a record. That could have been a data reporting issue, or it could have been genuinely that no test was undertaken.
Who did CAS send the results of this study to?
It wasn't something I was directly involved in, but I believe that they were shared with senior officials in the Welsh Government working in health and social care in around late summer 2020.
Finally, on this topic, the Vivaldi Care Home study was conducted by the ONS in the UK to measure the impact of COVID-19 in care homes in May to June of 2020. And am I right in saying that that study concluded that care homes using bank or agency nurses most days were more likely to have more cases of COVID-19, and care homes in which staff received sick pay were less likely to have cases of COVID-19 in residents?
I believe that's what the study found, yes. It's a study that just covered England, however.
You preempted my next question. Is any similar study being undertaken in Wales or has been undertaken in Wales?
So the report that you referred to with the bar charts in it does refer to a particular piece of research by Public Health Wales, where they had looked at the risk factors associated with outbreaks in care homes. And I think they had found, if you'll excuse me reading it so I don't get it wrong, but their conclusion was that they found that large care homes were at considerably greater risk of outbreaks throughout the pandemic, and the exposure to discharge from hospital was not associated with a significant increase in risk after you take into account the care home size.
My final topic is about data sharing. Firstly, between CAS and the Welsh Government and the UK Government. In terms of the speed of data sharing, Glyn Jones, in his statement, describes how for some areas the flow of data was generally slow or inhibited from the UK Government's end to the devolved administrations, and he particularly cites the Department for Work and Pensions. Do you agree with what he says about that?
Yes, I do agree with that.
Are there any other examples of areas that were particularly affected by delayed sharing speeds?
I think the Department for Work and Pensions data sharing is probably the most noteworthy one. There were examples of very good data sharing. The Department for Transport, for example, was incredibly helpful in sharing data around mobility and trips that people were taking. Generally, data sharing was quite positive, so those exceptions were few and far between. One other that's worth noting, perhaps, is that we've been looking to acquire the data from the Covid-19 infection survey for sale, which is something we've not been able to do yet.
In terms of data sharing and conformity of data sets, we know that each of the 4 nations had their own data sets and means of measuring COVID-19 cases and deaths. Especially at the onset of the pandemic, is it correct that definitions across the UK were inconsistent in their recording of deaths? For example, how data on COVID-related admissions and hospitalisations were measured for each nation, and the fact that Wales included suspected cases for some measures where other nations didn't.
On hospitalisations, yes, that is correct. Broadly, we were able to work together to understand the differences, but at the outset there were certainly differences there.
And were those differences that were worked out quite rapidly in the course of the pandemic?
So I think perhaps those differences carried on throughout the course of the pandemic, but we were able to understand where we could and couldn't compare data better, if that makes sense.
Are any steps in motion to attempt to harmonise that kind of data collection for future?
So I think we've probably learned quite a lot from that experience. I think each nation, in an attempt to be helpful, moved quite quickly to start collecting its own data, but that then potentially meant that we had some small differences in the definitions we used across the UK. That's something we've learnt from in, for example, the response to the invasion of Ukraine and the data-related demands for that. We worked together across the nations to come up with a single set of statistics. So it's about learning to take a couple of days to work together to avoid those kind of issues in future.
My final question is about the ONS. Professor Sir Ian Diamond earlier today was asked whether there were any challenges in collaborating with CAS during the course of the pandemic, and he said that there weren't any. Is that something that you agree with?
We certainly had very positive relationships with the Office for National Statistics. We were involved very closely in things like the development of the COVID-19 infection survey. They were very amenable to our requests for data and for additional analysis. However, I do think they were probably more closely embedded with the UK government than perhaps the Welsh government, and that potentially meant that UK government requests were perhaps prioritised or understood more than requests from the Welsh government.
My lady, those were all of my questions.
Thank you very much. I think, Ms Scanlon, you've got permission for some questions.
Thank you, my lady. Ms Howarth, I ask questions on behalf of COVID-19 bereaved families for Justice Cymru. Firstly, in respect of the COVID-19 Analysis Hub established on the 23rd of March 2020, just briefly, you've described today that the responsibility of the hub was to bring existing information together for use within Welsh Government. In other words, it provided COVID-19 statistical analysis to inform advisors and decision makers in the Welsh Government. Is that a fair summary?
Yes.
So an important function.
Yes.
The former Chief Statistician, Glyn Jones, states in his witness statement that the hub started life as a team of 7 people. Is that correct?
That is correct, yes.
And initially, did the staff in the hub act on a voluntary basis alongside other responsibilities?
That is correct, although most of those other responsibilities were largely paused, which enabled them to contribute to the work of the hub.
And that may answer my next question, but do you consider that the limited team of 7 and the fact that staff were acting on a voluntary basis alongside other responsibilities, did that in any way impact on the hub's ability to respond to requests in the early stages of the pandemic?
So there were a range of other statistical and analytical staff also supporting the hub, so they weren't the only people responding to requests. So if an example would be helpful, the team that leads on economy and labour market statistics would help contribute to work around that topic related to the pandemic. But that notwithstanding, I think it was a big ask for a small team to be able to accommodate the growing number of analytical demands during that time.
And certainly, Glyn Jones suggests that by the summer of 2020, demand was outstripping supply. Is that fair?
Yes.
And what impact do you think that had on the hub's ability to respond to policymakers to inform decision making?
So I think we did the key information was made available and we were able to work with policy officials, but perhaps the thing that we were less able to do was be more proactive. It was much more reactive to the kind of demands that people had for statistics during that period, rather than more closely embedding yourself with the policy team.
And in future, what lessons do you think that can be learned from that scenario?
I think it shows that you need suitable analytical capacity within an organisation to be able to work collaboratively with policymakers. I don't necessarily feel like there was a deficiency in the use of analysis, but I think that we potentially could have gone further in anticipating some of those demands, but also it creates a significant impact on the small number of individuals concerned in terms of their own well-being, and I think a large capacity can help avoid some of those challenges as well.
Avoids burnout.
Yes.
Yeah. Secondly, we know that 5 new analytical posts were agreed in June 2020 for the hub, and 6 new posts were agreed in November 2020. What isn't clear from the evidence at the moment is whether those posts were filled. Are you able to assist?
They were, but it took a period of time for them to be filled.
Do you agree with your colleague Lynn Jones that notwithstanding these vacancies having been advertised and indeed as you've set out eventually being filled, recruiting sufficient specialist resources remained a constant challenge throughout the pandemic, and secondly that this meant that certain projects could not be adequately resourced?
It was a challenge to resource analytical roles. There are only a finite number of analysts within government. We benefited from being able to bring in, for example, colleagues from arm's length bodies. We had a small number of loans from the Office for National Statistics. But it was a continual challenge to be able to fill the analytical capacity that we needed.
And in terms of the second part of the question, did that mean that certain projects couldn't be adequately resourced?
There were... Generally, I think it probably meant that we were slower to do things than we might have liked, rather than they couldn't happen. But there were some examples where one particular noteworthy one was the technical advisory cell had an internal dashboard that they had brought together to interrogate some key sets of data. I would have liked that Knowledge Analytical Services, together with our digital colleagues, would have been able to do that, but we didn't have sufficient capacity to be able to do that. So that was something that was contracted out.
And aside from that example that you've given, how else, if at all, did the resourcing constraints impact on policymakers during the pandemic?
I think broadly we were able to meet policy demands. I can't think of a specific example that impacted policy making, but it did often mean that people had to go above and beyond and work long hours to do so.
Thank you, Ms Howarth. Those are my questions. Thank you, my
Thank
lady.
you very much. Mr Gardner, I gather a question the Children's Commissioner would like asked.
Brief, my lady. I wonder if I would lean forward and obtain
A lectern for one question, Mr Gardner.
It's my eyesight, my lady.
Actually, it's the use of technology, isn't it? I hadn't thought about that.
Ms Howarth, the inquiry was just heard from Professor Diamond. I don't need you to turn to it, but in his first statement to paragraph 166, he refers to a school infection survey and notes that that was an England-only study. Are you able to confirm if any equivalent study was taken during COVID relating to Wales?
There wasn't an equivalent study in Wales, no. I recall that we had discussions with ONS about their survey to understand how it worked, determine if it might be possible to extend to Wales, but from memory, I recall it was quite an expensive survey to get up and running, and there wasn't necessarily the funding available to do that.
See, so you wouldn't have been involved in risk profiling, but correct me if I'm wrong.
No.
But the result of that would be that those who were making decisions about risk profiling wouldn't have had data available to them specifically about schools in Wales then?
It depends what data you mean. So they wouldn't have had that specific data from the infection survey, but there were other sources of data. Colleagues in Swansea University, for example, had linked together a range of data to understand transmission in schools. So there were a range of different data sources, but the school infection survey run by ONS was an England-only survey.
I'm grateful. Thank you, my lady.
Thank you, Mr Gardner. I think you have one further question that John's campaign wishes you to ask. Yes, Ms.
Yes, I do, my lady. Thank you. Ms Howarth, you confirmed that the rapid surveillance data did not cover all deaths. It did not capture all deaths in care homes, but that ONS data would have captured all of those deaths. How did the publication of that data work?
Of the ONS data?
Of the ONS data, yes.
So ONS published that data on a weekly basis, I think it was, with a approximately 10-day lag, I believe, from memory. And I think as part of that, they would regularly break down data by place of death. I think it might also be useful to add that we shared data from the Welsh Government with ONS, the Care Inspectorate Wales data I mentioned, which helped them to produce their analysis around deaths of care home residents as well.
In sticking with the ONS data, would earlier figures that may not have included care home deaths have been updated retrospectively when the complete ONS data was received?
So I'm not an expert in ONS's mortality data, but my understanding is it should cover all deaths that have a death certificate. So that would be regardless of where the death occurred. So they should all be in there, is my understanding.
Forgive me, I think the question simply is about whether earlier figures would ever be corrected to account for later figures.
I'm not clear on how the ONS mortality data works, but I imagine that there would be updates for any late returns, for example, or delays in registration that were received.
I'm grateful, my lady.
Thank you very much indeed, Ms Spector. Thank you very much indeed for your help. I'm very grateful
Thank you.
to you. And we'll break now, I think, well, might as well between witnesses. And I shall return at 3:15.
All rise.
Can I call Dr. Robert Hoyle, please?
Dr. Hoyle, if I can ask you to repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the
the
truth,
whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Dr. Hoyle, could you start, please, by giving us your full name?
Robert Thomas Hoyle.
Thank you very much for attending today and giving your evidence. Can you please remember to keep your voice up so we can hear you, but also so your evidence can be recorded. If at any stage you need a break, do say, and if I ask you anything that you don't understand, please ask me to rephrase it. Your witness statement for this module of the inquiry is at INQ 000347980. We see the first page there. We don't need to go to it, but page 26, you signed that statement on the 30th of October last year. Can you confirm that the contents of that statement are true to the best of your knowledge and belief?
It is.
I'm grateful. Dr. Hoyle, are you at present the head of science for the Welsh Government Office for Science?
I am.
That's a role you've held since May 2019.
Yes.
Before that, you worked in the Welsh Government Science Division to support the then Scientific Advisor for Wales, who was Professor John Harries, and you managed the Engineering Centre for Manufacturing and Materials. And prior to 2010, you worked in the engineering, energy and manufacturing sector. Is all of that correct?
Yes.
Is it also correct that you have served all 4 officially appointed Chief Scientific Advisors for Wales?
Yes.
Can you please provide a very brief overview of the roles and responsibilities of the Head of Science for the Welsh Government?
My main role and principal role is to support the Chief Scientific Advisor for Wales, of which we've had 4 that I've served. And that is principally about providing scientific advice and evidence to government, although we do other things. One of the pieces of work that we are doing at the moment is related to medical radioisotopes, and that is quite a technical issue related to the supply of medical radioisotopes to the NHS and other health services. So, but that again is about collecting evidence and data and information to support policy development or strategy development.
Just help us, where does your office sit within the structure of the Welsh Government?
So the Chief Scientific Advisor is a public appointment and normally reports to the First Minister, although for pay and rations, if I can use that phrase, we sit within ETC, which is Economy, Treasury and Constitution at the moment, but we sit within the economy portfolio of the Minister, Vaughan Gethin.
And as a very broad overview of your role during the pandemic and the various advisory groups that you served, I think I'm right in saying you were a member of the Technical Advisory Group from the 13th of April 2020. That's what's known as TAG.
Yes.
And you were also a member of the Technical Advisory Cell TAC from mid-April 2020. You were also a member of the International Group and, in fact, chair of the International Intelligence Subgroup from September 2020 to the end of 2022. Is that right?
That's right.
And that's the International Intelligence Group, perhaps I think known shorthand as Intel. Is that right?
Yes.
Now, one of the issues in this inquiry is the degree to which the Welsh Government understood and engaged with pandemic strategies of other countries as a potential model or as a guide for their own pandemic response. So as the chair of Intel, you were involved in the surveillance and collection of data from other countries' pandemic responses. Is that right?
I was, yes.
Can you briefly explain to the inquiry the purpose of Intel?
The main purpose, as set up, was to observe what was happening elsewhere in the world and to see whether lessons could be learnt from elsewhere in the world that might be applicable to Wales.
And am I right, Intel was set up in September 2020?
Yes.
And how did Intel come to be established at that time during the pandemic?
Prior to that, and right from the start of the work, we started in March, we started to look at, within the Welsh Government Office for Science, what was happening elsewhere within the world in different countries to see how the pandemic was developing in different countries. And then over a period of time, it was felt because of things that were happening within TAG that we should formalise it more by creating an international subgroup of TAG. So we went from being a sort of localised activity within the Welsh Government Office of Science to a broader activity which included a range of experts from external to the Welsh Government.
So the surveillance and collection of data from other countries was going on within TAG from March 2020, but it became formalised and put into a specific subgroup in September 2020. Is that accurate?
Not quite accurate. It was the international intelligence work that was going on was conducted by the Welsh Government Office for Science, principally myself and members of my team. And then I reported to TAG on a regular basis, the International Situation Report, as it's often or was often known. So I reported not every week or not every meeting, but on a frequent basis about what was happening elsewhere. And then when other subgroups were being formalised and sort of growing out of activities and the need to pursue discrete lines of research or evidence gathering, then I formalised it into an international group at what became Intel in September of 2020.
I understand. And what kind of requests were made about international comparisons? What kind of evidence or information was sought from Intel?
From TAG or from elsewhere?
From TAG?
Right. Initially, we had requests that came through TAG from ministers or directly from TAG meetings to investigate issues that were relevant at the time. One of the issues that we looked at in considerable depth was the difference between the pandemic in Latin America and how that was progressing to how it's progressing in Western Europe and Northern Hemisphere. And what we're looking at there to see whether there was a difference between Northern Hemisphere and Southern Hemisphere developments of the pandemic. Of course, this comes down to seasonality and whether the pandemic had a strong seasonal component to it or not. And so we looked at the different hemispheres at the same time because they have different seasons. It's summer in the Northern Hemisphere, it might be winter in the Southern Hemisphere. So that was one piece of work that we looked at. Another piece of work we did was on the R0 and R0 value. And we submitted a paper to the First Minister on that. But it varied. On the requests that were made of us were varied. But that didn't stop us exploring our own issues where no requests were forthcoming because we were observant about what was happening at the time and we picked up on things that we thought would be interesting to investigate.
I think you say in your witness statement that many requests were verbal and knee-jerk or had a panic flavour about them. Is that right, that it was more reactive than formal, considered commissions?
Certainly in the early days, yes. Things were happening so quickly that a sort of more formal commissioning system didn't materialise. The requests were typically in meetings, please go and have a look at whatever, in TAG meetings, and we would go off and have a look at whatever and report back. Over time, that became less panic-stricken, shall we say, or panic-stricken is not quite the right word, but fast-moving.
You referred to some countries that you looked at data from. Did you consider data and intelligence from Southeast Asian countries, so for example Taiwan, Vietnam, South Korea, who already had extensive experience and effective mitigations from viruses such as SARS?
Yes, we did.
In the course of evidence tomorrow, the inquiry is going to hear from Dr. Roland Salmon, who is an advocate for a Welsh approach to the COVID-19 pandemic that more closely resembled Sweden's response to the pandemic. Is that a matter that you considered in Intel?
At great depth, yes.
Could you just provide the inquiry with a brief overview of the course charted by Sweden in the course of the pandemic and how this differed from the Welsh approach?
Sweden didn't insist on a harsh lockdown in the manner that many other Western European countries did, or indeed countries across the world did. They had a much more laid-back approach to it. And in the early days, it looked like they were handling the pandemic more effectively, which raised the question about the effectiveness of lockdowns. However, when we dug into it in a bit more detail, it became obvious, and one clear point became obvious to us. The number of single occupancy households in Sweden is much higher. That's one person per household, is much higher than in Sweden than in many other more populated and more densely populated countries. So they had a degree of built-in self-isolation that many other countries didn't have and don't have, which meant that you can't make direct comparisons between densely populated countries and less densely populated countries like Sweden.
I think you may be already close to answering this question already, but what are your views about the viability then of Wales and the UK in general mirroring Sweden's strategy?
We have much greater densities of population and much higher population in our major cities than many parts of Sweden. So I don't think you can draw the same conclusions or lessons from Sweden and expect them to work in the UK. The conditions are different.
Did you receive proper feedback on the work that Intel did? Did you feel as though you received sufficient consideration?
From TAG?
Yes.
It was variable. On several pieces of work, we received no feedback. On other pieces of work, we did receive feedback, but it was somewhat ad hoc. But there again, that was partly a reflection of the rapid changing nature of what we were doing and looking at. Quite a few of the things that we looked at and were requested to look at, things have moved on by the time we'd looked at them, because inevitably it takes time to look at some of these things. But overall, there were times when I wish there could have been more feedback.
And who would you say is responsible for the lack of feedback?
That would come down to the chair and the deputy chair.
Do you feel as though TAG and TAC and Welsh ministers took Intel sufficiently seriously as an information resource during the pandemic?
Sufficiently, perhaps not sufficiently seriously. I think a lot of the focus, and rightly so, of TAG and TAC was what was happening in Wales. And that meant that they didn't have necessarily the bandwidth to cover, much broader perspective as to what was happening in the rest of the world. They did take great notice when things like the new variants started to appear, like the Delta in India, or the Brazilian variant, or the Omicron variant, and so on. But there again, that was transitory because things were happening so quickly. And the threat to the UK was obvious, and so they took much more interest in what we were doing.
Do you view this, if I call it sort of insularity, as a shortcoming, being too Welsh focused?
I wouldn't say it was a shortcoming, no. I think it was an insufficiency, but not a shortcoming.
Now, during the course of the pandemic, did you attend most TAG-TAC meetings?
Yes, apart from on the occasion when I was actually on holiday, I made a point of attending every single one of them.
And how or by whom were the discussions and advice formulated by TAG communicated onwards to the Welsh Government and ultimately the Welsh ministers?
As I understood it, the information that we provided was assimilated and assessed by the TAG-TAC leadership, the chair and co-chair, and then passed on as appropriate to the chief medical officer and other Welsh Government people, and ultimately to ministers.
How transparent was that communication of advice to Welsh ministers through either the CMO or the Chief Scientific Advisor for Health?
It wasn't particularly transparent, but that's not to say that it wasn't happening. It was just that we didn't witness it. I didn't witness it to any great extent.
Did you ever see any kind of record of what advice had been given verbally from, say, Dr. Atherton or Dr. Orford to Welsh ministers?
No.
If there had been dissent or debate within TAG, are you aware of whether that debate was accurately conveyed to the Welsh Government, Welsh ministers?
I can't answer that, I'm afraid. I don't know.
Perhaps put another way, is TAG advice formulated as a consensus view or as an overview of a debate on any one topic?
Most of it was consensus view, yes.
So in that sense, similar to SAGE.
Yes.
Do you consider, in your experiences of TAG, that there was sufficient challenge on TAG and also TAC? Was there sufficient challenge on issues? Or was there a culture where people didn't feel able to speak up and challenge during a discussion or debate?
There was plenty of, can I use the phrase, soft challenge, but really hard challenge, I didn't feel there was sufficient.
Were there, though, meaningful debates within TAG and TAC that actually affected the advice or the outcome of the advice that was then passed on to the Welsh Government?
Oh, there's certainly debates. There were certainly debates, but it was done in a very collegiate manner. But I can remember on occasion there was serious challenge, really off-the-wall challenge, and I felt that at the time that wasn't particularly well received. Soft challenge was quite acceptable, and there was a lot of encouragement for soft challenge, but not really hard challenge of the type that, questioning whether lockdown at all was a good idea.
So, I mean, would it be fair to say that TAG was used by Welsh ministers as a place where information and advice could effectively be rubber stamped?
No, I don't think that was the case.
Were you and your colleagues on TAG informed about how your advice impacted policy? Did you see the advice feeding into policy decisions by Welsh ministers, or do you think you should have been appraised of that?
I think, yes. We, for instance, the firebreak lockdown, we debated that long and hard within TAG. And that did feed through to a lockdown, a firebreak lockdown in the autumn time of 2020, I think it was. So we debated it, and I think that did feed through into the discussions and decision-making by ministers.
And, Doctor, I'll come a bit later on to look at some of the TAG advice around the firebreak lockdown. Okay. Just before moving away from this topic, Welsh Government in general, as head of science, you suggest in your witness statement that the value of science was not understood by decision makers in Wales, and you say is fragmented across different portfolios in the Welsh Government. What impact do you think this had on the Welsh Government's response to the pandemic, and what lessons should be learnt from that?
That is a general statement rather than a specific statement related to the scientific advice being provided by for COVID. I think ministers did seek scientific advice on COVID-related matters, but my comment there was a more general comment about scientific advice generally informing policy and strategy within Welsh Government.
I understand. If we can now talk about the initial stages of the pandemic, so the particularly January, February, March period. You say in your witness statement that you were reporting to your son in the middle of February that COVID-19, in your words, will change the world. And you say by that stage, so again, this is mid-February, it was obvious to you that the genie was out of the bottle and that there would have to be a major intervention to prevent a dire outcome. Why was it obvious to you in mid-February that a major intervention would be required?
The rate at which it was spreading across the world and the number of countries at which it had started to appear, and in certain countries like Italy, the impact that it was having on some of the communities in, I think it was northern Italy, and not to mention, of course, the impact that it had on communities in China. So to me, it was obvious from the rate at which it was spreading within communities, but the rate at which it has spread across the world, it was more or less unstoppable at that point, and that, drastic action would be necessary.
Was this a commonly held view in the Chief Scientific Advisor, so that's Professor Halligan's office at that time, mid-February?
Not really, no.
So do you think that the Welsh Government appreciated the potential scale of the pandemic at that stage in mid-February?
I think it was dawning on certain people, yes, and the Chief Scientific Advisor for Health, it was dawning on him the scale of the challenge here, or the scale of the threat.
When did you start discussing the pandemic within the Chief Scientific Advisor's office?
The week before the lockdown, approximately. I think I gave my date in my statement, and I made a note in my diary of, started work on COVID. But although I had, of course, started work long before then, I've been monitoring it since December 2019.
So you've identified in mid-February that a major intervention would be needed to prevent a dire outcome. And yet in the Chief Science Advisor's office, COVID was not discussed until a week before lockdown. So that would be sort of a week before the 23rd of March.
The Chief Scientific Advisor for Wales, I did raise it with him on occasion, but it was a case of that's someone else's problem. That was the response that we had.
So that was Professor Halligan's response to you informing him of your views.
He didn't state that, but that was the implication of his actions or lack of actions, that it wasn't for him and that it would be a health issue.
Do you consider that action was required by the Chief Science Advisor?
For health or for Wales?
For Wales. So
Wales.
We're talking about Professor Halligan, your office.
I went out of my way to encourage him to engage in this and to do things. He eventually took that and advice, but not until very late in the day. I think he could and should have done more.
And what is it that the CSA and the CSA's office could and should have been doing in terms of preparedness and response in this period, mid-February to mid-March 2020?
I think engaging much more closely with the Chief Scientific Advisor for Health, the Chief Medical Officer, ministers and others, and offering to engage and offering to undertake whatever was requested of them. So in offering work.
Now, was the work that you've just identified as what should have been doing, was that work picked up by others? So, for example, the Chief Scientific Officer for Health, Dr. Orford.
It was, after the lockdown, that's when we got engaged in TAG and TAC. So I don't know how it happened, but I think the request must have come through, and the expectation that at least we should engage in TAC and TAG, if nothing else.
Did you find it a difficulty at the time reporting to Professor Halligan, on the one hand as the chief scientist, and Dr. Orford in your capacity as a member of TAG and TAC?
There was no difficulty, no.
Now, in your opinion, was a national lockdown necessary in March 2020?
Yes.
Do you think greater regard should have been given to the experience of countries that were several weeks ahead of the curve? So you, I think, mentioned Italy earlier, in the lead up to that decision to enter a national lockdown.
Well, I think at UK government level, they were looking at what was happening in other countries and the necessary for regional or total national lockdown. Within Welsh Government, I wasn't privy to any discussions regarding lockdown. I wasn't aware that a decision had been made by ministers and an approach to UK government to seek a national lockdown. I wasn't aware of that until January this year. My view at the time was that the leadership and decision-making came from UK government rather than Welsh government, although I've since learnt that the Welsh First Minister, the Scottish Minister, First Minister of Northern Ireland Minister approached UK government Prime Minister the day before the national lockdown was announced. That's how I understand it happened, but I didn't learn that until, as I say, January this year. It wasn't visible at the time.
But in terms of what you knew from your own experiences at the time and in the position you were in the CSA's office, and also by the end of February, TAG had been established, your impression was that this was, there was no discussion of a national lockdown, this was something being led by UK government?
That was my impression at the time, yes.
Doctor, I'm sorry to interrupt. You said that lockdown in March 2020 was necessary. Is that because you believe it was inevitable because of the spread of the virus, or had it become inevitable because not enough had been done early enough?
It was inevitable because of the spread of the virus.
So you think even if other things had been done earlier, we couldn't have stopped the lockdown? And supposing we'd been better prepared, for example, supposing people had acted more quickly.
I think by the time that the discussions were being had, it was probably too late to avoid a lockdown.
Well, that's really what I'm asking. Had more been done earlier? We'll never know.
We'll never know, but looking about what happened subsequently, I think by the time that January came along, it was already too late to avoid a lockdown.
Right. Thank you.
And at the time, did you think lockdown should have come sooner?
Yes.
How much sooner?
In my statement, I say possibly up to 2 weeks earlier. I think 5 to 7 days earlier would have been appropriate. And I think there's a subtle timing issue here. We value our freedoms as a democratic country and the ability to move around and all the rest of it. And so it needed to get to a certain stage before widespread lockdown would be acceptable to the national population. So it's a timing issue. I think we could have gone probably 5 to 7 days earlier than we did, but it needed to become prominent enough in the population's mind and the threat obvious enough for a lockdown to be acceptable. So it's a trade-off.
So in terms of what you attribute the delay in implementing the first national lockdown, would it be right to say that you would say it was due to a lack of political leadership or a lack of political confidence in making a unilateral decision to lock down?
What do you mean by unilateral decision?
Obviously, we're looking at the Welsh government.
I think it would have been untenable for the Welsh government to make a unilateral lockdown ahead of a UK national lockdown. And I think ministers realise that because we are such a small part of the UK in population terms. I think the challenge, there would have been huge challenges in getting the population to accept it. And not only that, the political ramifications and accusations, as we've seen with many other things not related to this. So I think it was a national lockdown or nothing.
And did TAG have involvement in the decision to lock down? Was TAG commissioned to advise on the national lockdown?
I wasn't part of TAG at that time, so I can't comment.
In your view, if the lockdown had been implemented earlier, what effect would this have had on the first wave case progression and fatalities?
It would have smoothed the peak and it would have prevented as many people being infected. and fatalities, we reduced the number of fatalities in the first wave.
And what about across the extent of the pandemic?
I'm not convinced it would have made that much difference over the whole lifetime of the pandemic until the point at which the whole population was effectively immunised either through infection or immunised through vaccination.
Do you mean by that that even if you had managed to flatten the peak or whatever the different analogies are that people use in the first wave and therefore reduce the number of infections and deaths, you were always going to get the second wave and therefore overall the number of infections and deaths would have stayed the same? Is that what you're saying?
Yes.
Thank you.
Moving beyond the lockdown into perhaps the summer of 2020, did you think that TAG-TAC had a clear objective following the lockdown of what Welsh ministers were trying to achieve with their NPI strategy? So, for example, minimise fatalities, expedite a way out of lockdown, protect vulnerable groups, so on and so forth.
I asked the question on my first meeting about what the strategy was, and essentially it was to reduce harm or harms. And I was never convinced that it was any clearer than that.
What are your views on the effect of Eat Out to Help Out on the transmission of the virus and caseloads in the autumn and winter of 2020?
In a small way, it contributed to the re-emergence of into a new peak, but no more so than many other release activities that were going on at the time through the summer of 2020, allowing people to go on holiday and that kind of thing. So it was part of the cause of the spread of the next virus or the next wave. The virus had never gone away, and still hasn't. So all that had been happening is we suppressed it. So it was, to my mind, it was inevitable that it was going to come back, which is what it did.
And am I right in saying that TAG and TAC, they weren't commissioned or asked to advise on the Eat Out to Help Out scheme, to your knowledge?
To my knowledge, yes.
Now, you've mentioned the firebreak lockdown already. What are your views on the need for a firebreak lockdown in October 2020?
It was necessary to flatten the curve.
Can we please have INQ 000313251 on the screen? These are tag notes from the 18th of September 2020, which analysed the worsening picture across Europe. If we just look at the bottom of that page, please. Starting, the most recent data has shown that in Spain, incidence per 100,000 has raised across the country dramatically. France has also changed rapidly in the last fortnight. Indications are the UK is currently travelling down a similar path. So, just pausing there, you say indications are the UK is currently travelling down a similar path. What did you make of this worsening picture in mid-September 2020?
That a new wave was developing.
Did you think that this signalled the inevitability of a further lockdown to control those growing case numbers, or were there windows for earlier or different or less stringent intervention measures, in your view?
In my view, as I said on several occasions to the technical advisory group, MPIs and harsh and rigorous application of MPIs do work to suppress the virus and the pandemic. So I think, given what was happening in Spain, and you just looked at the trajectory and the rapid increase, almost an exponential rise in cases in Spain and other countries, the UK was showing very, very, very similar characteristics. So in my mind, it was inevitable that some kind of intervention would be necessary. It's just a matter of when and what. But given the nature of these things, the what tends to be a lockdown or firebreak or whatever.
And what is your view on the the purpose of a firebreak lockdown and the consequences that that might have on the overall course of the pandemic?
The main purpose is to stop the health services from being overwhelmed by a massive wave of infections and seriously ill people.
And in respect of the Welsh firebreak, do you think that the decision to impose it when it was imposed was taken at the right time in Wales?
Pretty much, yes.
And what about the length of the firebreak? We know it was a 2-week firebreak that spanned 3 weekends. Was that long enough, in your opinion?
Probably. It's whether it went on for a few more days you could argue about, but I think it was appropriate length. Yes. Partly it's about mindsets and introducing or reintroducing a certain mindset in the population to say that if we don't undertake certain protective measures, then this thing is going to get out of control. And so there is an expectation that government does something, and this is government doing something, which sets the mindset for the population. So it's as much as a psychological thing, I think, as a real control of the virus. But certainly a lockdown will control the virus or suppress it.
Now, Dr. Hall, just changing topic, want to talk to you briefly about discharge from hospitals into care homes. Were you involved in the decision to discharge untested asymptomatic patients into care homes from hospitals?
No.
Or was TAG involved in that decision?
I don't know whether TAG was involved, but I think that was probably before my time, TAG.
And you referred earlier in your evidence to there being a lack of hard challenge in relation to some issues that were raised with TAG and TAC. Are you able to help us then? The answer may be no, given the answer that you've just given. But in respect of this decision to discharge untested asymptomatic patients, was that subject to hard challenge within TAG or TAC?
I think the decision was made before I joined TAG, so I can't say.
If we can please have a look at INQ 000384698. This is an email that was sent 30th of April. It's an email that I think, in fact, you sent to Dr. Rob Orford and Fliss Bene concerning, as we can see from the title, the subject, FM's First Minister's comments about no value in testing in care homes. And you write, Dear Rob, Fliss, Peter Halligan is keen to understand the rationale, evidence and advice behind the First Minister's comments last night on the telly that there is no value to testing for Covid-19 in care homes. Please, can you enlighten us? Thanks. Why did you feel the need to send that email? What did you think of the Welsh Government's approach to discharging patients from hospital into care homes at that time?
There's two things going on here. One is discharging patients from hospital to care homes and whether they are tested or not. And then there's the ongoing issue of testing patients and care home occupants on an ongoing basis. And they're not quite the same thing. And I think this relates to testing of people in care homes, not testing prior to discharge from hospital to care homes. So I think we need to be careful about conflating two different things here.
No, obviously there are two issues, but you here are raising with the Chief Scientific Advisor for Health, Dr. Rob Orford, a point about something that's been said by the First Minister about there being no value to testing for COVID in care homes. And I just want to know, why did you feel it necessary to send this email, having heard that?
Okay. This is not my normal way of phrasing such emails. I made it very explicit by stating Peter Halligan is keen to understand, not me. And so it was in a response to a request from Peter Halligan that I send this request. Normally I would say a little bit less tersely than this, or frankly than this. So the way I read it now, and I do have a vague recollection of it, it was a specific request from Peter Halligan for me to send this request off to Robin Fliss.
Do you share either the concern or perhaps it's just a question as to why the First Minister made the comments that he did? Do you share Professor Halligan's concern?
Well, I think there's a real issue, again, coming back to the difference between discharging untested people from hospitals to care homes, and that's different from the issue of ongoing testing of care home residents. Now, I think there isn't a lot of benefit in ongoing testing of care home residents, so long as they have been well isolated and protected. There is a lot of benefit in testing people who are being discharged to care homes, so as to prevent influx of asymptomatic people, but infected people that would impact other residents of the care homes.
Now, in your witness statement, you link discharges to care homes with the fact that COVID-19 is an airborne virus. What is the relevance of COVID-19 being an airborne virus on this question of hospital discharges? And what consideration was given to whether COVID-19 was, in fact, an airborne virus at this time?
At the time, there was a lot of debate about whether it was actually an airborne virus or whether it was passed by touching or fomites, I think the phrase is used, objects. My view at the time that it was pretty obvious that it was an mainly airborne transmissible virus. The impact that would have would be on control of asymptomatic but infected people within care homes, and the threat that uncontrolled discharge, the threat that would pose to other care home residents.
And those concerns that you've just expressed to us, did you raise those concerns at the time, how that might affect hospital discharges to care homes, either within TAG or within the CSA office?
I don't believe I did, no.
Do you think you ought to have done at the time?
Yes. And to follow up on this, we did look at testing and regime testing across different European countries in care homes and other healthcare settings. And we did prepare a paper on that, which is not part of my evidence, but we did, and I have it with me at the moment.
Now, Dr. Hall, just again changing topic and want to understand a bit more about the issue of behavioural non-compliance. So, as I understand it, during the pandemic in Wales, there were a number of hotspot areas or areas where it appears that transmission was high and perhaps compliance was low. And so, for example, there were concerns about high case rates and lack of isolation, lack of social distancing in regions like Caerphilly and Rhondda Syn on Taff in September 2020, leading up to the firebreak. You recall those instances.
Mm-hmm.
How did TAG approach the problem of differential transmission and differential compliance with MPIs?
Mm. I think with great difficulty. Although there were, MPI controls in place and expectations on the population to comply with the expectations of the MPI controls, it was obvious that certain areas and certain groups were not complying. But I'm not sure that TAG really had a solution to that.
And did the group of scientists who sat on TAG, do you think they fully understood or apprehended the nature and the causes of lower compliance in certain areas or amongst certain groups?
I think overall no. And I think the reason for that is most of the tag members didn't have the same life experiences that people who live in the more deprived parts of Wales or among some of the communities of Wales have and did have, and so couldn't relate to some of the motivations and behaviours that were being exhibited by some of these communities.
Would it be fair then to characterise this as a form of groupthink within TAG?
Groupthink by omission, perhaps, and unconsciously. Yes, I think there was a degree of soft groupthink based on the nature of the membership of TAG. If I could explore that a little bit more, virtually all the people who are members of TAG were either public sector, HE, or other, the health sector people, all of whom could work from home on a regular basis. And so they didn't have the same lived experiences as other parts of the population. So from that respect, there was a degree of unconscious bias.
I mean, could that have been remedied perhaps by commissioning more evidence in the area of behavioural science? I mean, should there have been more data about behavioural science to inform TAG's thinking in this area about non-compliance with MPIs?
Only limitedly. I think the best way to have addressed that would have been to invite other people from other walks of life to the TAG activity. Inevitably, if you commission a piece of behavioural science advice, it's done by academics in academia who are experts in sort of behavioural science, rather than experts in lived experience. And I think there's a subtle difference there.
Was non-compliance attributed to behavioural fatigue?
Partially.
And do you think rightly?
Inevitably, I think, rather than rightly.
Now, the inquiry has seen a 5th of June 2020 TAC summary of advice document, which includes a sage advice in it, advising on the increased risk from COVID-19 to minority ethnic groups. Now, I don't propose to display the summary of advice for the purpose of this question, but the advice suggests that this should be urgently investigated, with consideration given to how enhanced risk of poor outcomes could be managed and reduced. And the inquiry heard yesterday from Professor Ogbonna about how Black, Asian, minority ethnic COVID-19 advisory group, how that came to be established, how it then reported later in June 2020. And in your view, were issues about the need to understand and mitigate the factors that made certain minority groups more vulnerable to poor outcomes sufficiently considered before June 2020 when that advisory subgroup reported?
This is a very difficult area. My view that there was people were inhibited from discussing frankly and objectively and dispassionately some of the issues involved. And I think you've just demonstrated that, if you don't mind my saying so, by saying you're not going to display the evidence in this hearing.
Well, I think, in fairness, that's a limitation of time, and because it's a long document,
Okay.
Doctor. But in terms of you saying people felt inhibited, I just want to explore that with you. What do you mean by people felt inhibited?
The whole issue about religion, ethnic minority, disadvantaged people, is LGBTQ as it now is quite emotive. And I think there was a reluctance among some to really explore some of the issues involved in any great depth.
And what was the effect of that reluctance? That meant it simply didn't get discussed, didn't get looked at by TAG.
Well, some of the symptoms were looked at by TAG, but I think the attribution of cause was not necessarily appropriate. There was a desire to try and attribute cause to populist things, if I can use that phrase.
If I can just ask you also to keep your voice up, please, for the stenographer. Thank you, Dr. Hoyle. In conversations had by TAG, what reasons were ascribed to higher transmission and higher fatality and mortality rates amongst Black, Asian, minority ethnic groups?
Well, I think there's a tendency to try and attribute it to some of the inequalities, societal inequalities that exist. At the time, there was a lot of people within the health professions who were ethnic minority, and they were being exposed because of their line of work, and there was a sort of view that maybe this is because of the increased infection rate amongst these people was due to their ethnicity rather than a disproportionate large amount of them in a noble pursuit such as the health service.
You referred earlier to an issue that you had with TAG. You said lack of lived experiences or lack of similar lived experiences. I mean, does this indicate a lack of diversity also on TAG?
A lack of social diversity, yes. Not necessarily ethnic or religious diversity, but a lack of social hierarchy diversity.
Changing topic, talk about face masks now, briefly. We've heard your evidence about COVID-19 being an airborne virus and the concerns that you had about that and TAG's approach to this issue. Were you present when TAG discussed the question of face masks throughout the spring and summer of 2020, or was that before your time?
Well, from when I joined TAG in April 2020, I would have been present, yes.
And so can we just please have on screen INQ 000221076. This is I think it's an Intel report produced on mask wearing based on emerging evidence. It's dated, as we can see from the top, 20th of January 2021. Are you able to briefly summarise the key findings of that report, Doctor?
Yes, the key finding of this is that face masks prevent transmission. The best advantage is it prevents transmission or helps prevent transmission from people who are infected. And there was reasonably good evidence so that if you are infected and you wear a face mask, then the chances of you transmitting it to others is reduced because the viral particles are caught within the face mask. There is less good evidence to protect people who are not infected from picking up the virus from airborne virus, although it's debatable whether there is a small advantage.
Now, we know that Wales mandated the use of face masks on the 14th of September 2020, which was significantly later than other European countries and later, certainly, than England, Scotland and Northern Ireland. And it was a significant difference between the four nations of the UK. Do you think that that was the correct approach for Wales?
No, I think we should have mandated it much earlier than we did.
And when you say much earlier, when do you think it
At
should
least
be?
as early as the other nations of the UK.
Is the fact that Wales failed to mandate the wearing of face masks earlier and adopt, perhaps one might say, a more precautionary approach, is that a further example of perhaps a reluctance or reticence on the part of the Welsh Government to learn from actions of other countries? I referred earlier to a sort of insularity. Is that an example of that or not, in your view?
I think at the time, if memory serves me correctly, the evidence wasn't very strong. This report here, of course, postdates that. This is into 2021. So I think another 4 months or so after we mandated it in Wales. The evidence wasn't very strong, and I think Welsh Government ministers and their chief medical officer decided on the basis of the weak evidence that it wasn't appropriate to mandate face masks in public places. I don't think that was quite the right approach. I would have gone earlier, as I said earlier. Okay, I'm going to stop there, unless you've got more questions.
Let's move to an MPI, social distancing.
Yeah.
You explain in your witness statement that there was no science, you say, to underpin the extent of social distancing in terms of meterage. Is that right?
Yes.
Is that something you raised, or was that something that was discussed within TAG at the time? And if so, what were those discussions?
I vaguely remember some discussion about this, but it wasn't a particularly hot topic that I recall. The whole issue about whether it was 1 metre, 1.5 metre, 2 metre, 2.5 metre, or some other distance. And I quote those because those were the numbers used by different countries and or World Health Organization advice and so on. So there was no clear advice or evidence from other countries about what was appropriate distance other than the obvious statement that further is better.
Obviously, there are a number of factors that are in play when making these determinations about distance, one of those being an economic consideration. And we know in the UK government in England reduced the social distancing from 2 metres to 1 metre, and the Welsh government didn't follow suit, and they stuck at 2 metres. Was that something that TAG was, or can you tell us, is that something you were involved in TAG or that TAG advised on?
We did report on, in our situation reports, Intel TAG reports, different countries and their social distancing. But again, I would say that further is better, so it would be better to maintain 2 metres rather than 1 metre.
The inquiry understands that you were asked to advise on school closures and looked at comparisons overseas about the first wave. Can I ask you, did other countries in Europe follow Wales's approach to close schools during October 2020 and then again during December 2020?
Some countries did, some countries didn't.
Was any country, to your knowledge, especially any European country, closing schools but at the same time keeping sort of hospitality open, or vice versa?
Without doing a detailed trawl through my notes, I don't know. I can't remember.
Dr. Hall, those are all the questions I've got for you. And I don't think there are any Rule 10 questions, my lady.
Thank you very much indeed, Dr. Hall. I hope we haven't kept you too long. It's very, very grateful for your help.
Welcome. Thank you.
Right, it's 10 o'clock tomorrow. Thank you very much.
All rise.